So we were going to go on obviously our vascular talk, but I didn't know if you wanted me to just kind of jump down that bandwagon and kind of give you some thoughts, or if you had anything for me from any of this stuff from last week, or anything associated with that.
I am really interested in the relationship that you're going to talk about the BPPV and the vascular. I'm interested in your thoughts around that and how you would implement that and sort of assessing that, what you would do.
Okay.
And then obviously what if you found something, or like how you would know that's contributing, or what you think. I haven't got through all the videos this week, but
okay. So two things. One, my thoughts on the relationship between BPPV and vascular, and then two, if you did find something vascular, what would you do? Was that your question?
Yeah, or how do you use your treatment to help with BPPV treatment, I guess is what I'm
okay.
thinking.
All right.
Yeah. And I'm just going to move around my kitchen to make my son lunch.
You are fine. You are fine. Do you want me to just chatter away?
Chatter away.
Chatter away.
I can speak because I've got headphones on that I can move around.
That is fine. What I will ultimately do, kind of once you get that going, I am going to pull up one of my ebooks that I wound up adding to Podia. I thought I had it in there, and it was just too big of a file to send by email. So but I'm going to bring that up because that's really going to answer your question for the most part. But from a general rule that we're looking at is when we talk vascular, two things to come to mind. One, is this something serious that I need to refer on, right? Is this actually a stroke in process, right? And we have our algorithm and stuff with that. So that we can talk about that later if we want. So we're kind of talking about, hey, what if this person's coming in and they're having recurrent BPPV going on, right? Or they just don't get the response from your positioning, which we'll get into another week on different modifications and maybe some of the why associated with that. But here is the main thought process that comes about how I relate some of this next stuff to BPPV. And quite frankly, what it does, it comes down to, let me share my screen. How do I do that? 1 second. Oh, here we go. Okay. All right. And that's not what I'm doing. Wow, 1 second. I want to just share my book. 1 second here. Here we go. All right, here we go. By any chance, can you see where I have this little book I'm scrolling through?
Yep.
Okay. So this is like a 31-page ebook. This is just we call it Cervical Spine Considerations for the Vestibular Clinician. So you can, it's a really easy read. You can pop that out in about 20 minutes. But I'm going to scroll down because we give a lot of the reasons why, this and that. But I am going to bring up this. So this is, for the most part, inner ear depiction. You probably know exactly what all that, but what it does, it has the vascular, the arteries on it, okay? And so what we're thinking about is, hey, these are organs that are kind of at the end of the road, or we call it end organs. And anything sort of further away from the body, if it's your fingers or your toes, if you have any type of thing going on in the human body. Say you're super cold, right? Your fingers get cold, your toes get cold, you get frostbite and stuff because it is bringing in the blood flow differently. Think of that almost as the inner ear and what is providing a vascular blood flow to it, okay? And for the most part, if we just think of the vertebral artery going into the basilar artery and then it transitioned to a smaller creek into the anterior vestibular artery, and then we go into the posterior vestibular artery, and you can see where that blood flow goes. And so knowing that, that's going to take us to a little bit more on some pathophysiology. Oh, I think I lost you. Did I lose you?
I'm back.
Okay, you're back?
Yeah, I just cut out.
Yeah. So did you see that picture there? Just so you can.
I did.
You can,
yeah,
all right.
I did see that.
So
picture.
that's just basically showing you. All right, this is an end organ. We got really, really teeny tiny vascular arteries that go to, say, your posterior semicircular canal. All right, let's just take that one for example. So then, if you scroll down, what we're talking about here is, all right, could we take this information and add what our treatments are going to be, which is your exact question. So I'm going to scroll all the way down. This is just some talk. 1 second. Let me see. Blah, blah, blah. Sorry. No, I'm going to go back up. Okay. This is the page. So for the most part, when we talk about PV, the main running theory, of course, is dislodge otoconia, okay? There is another thought process that comes around in terms of some microcirculation issues, okay, that is going to impact what the performance is of an end organ, which we know would be, say, the posterior semicircular canal. So if we think of something being disturbed going up to the basilar artery from the vertebral artery, hey, we are impacting any type of, having some sort of vasoconstriction potentially issues, which is going to change how oxygen gets to it, nutrients get to it, et cetera, okay? So taking that as a theoretical construct, because it is one of 4 pathophysiology of why we think this might occur. One would be Barré-Liéou syndrome. The other would be vestibular migraine. And then the main theory, which is what we normally treat as proprioceptive issues. But then we talk about the vascular issue. And that's kind of what this falls under. It's not as... It's not as talked about in the Western medicine as it is in the Eastern medicine. And I say that because when we get to some of the research here in a second, it's mostly Western medicine. That since I've written this, there have been some other things that have come about as well. But for the most part, because what they are thinking about from an acupuncturist standpoint is how can we promote local blood circulation? Okay, that's kind of the thoughts. And then they have these acupoints, right? And so that's kind of one of the general basic principles underneath the diagnosis of cervical spondylosis. So if I kind of go down a little bit, what the big cool article I like to bring up with this is this one by Wang et al. In 2018. And basically what they looked at is actually looked at, you know, like in the United States, we look at, hey, do you have dizziness? Do you have a negative Dix-Hallpike? What's your dizziness handicap inventory do? This research actually looked at blood flow. They invested blood flow supply via, they call it a mean blood flow velocity. They looked at that with vertebral arteries, both the right and left, and the basilar artery, as well as they call it the pulsatile index and resistance index. And for the most part, what I like to get into is that they actually tested these people who were dizzy, and they put them in actually 3 treatment groups, okay? one treatment group, and it was 90 patients, which really isn't that bad of a study in terms of, when we talk about studies. 30 people per group is pretty solid, to be honest. So they had 3 treatment groups. One was just a medication group, which is betohistine tablets, and the other 2 were actually acupuncture. Okay, now we can take this and we are going to connect it. Now, it doesn't have to be acupuncture, but it could be our manual therapy. And if I scroll down, what they did, they treated these people once a day and 6 treatments. Okay, and these are what they treated. Okay, so I don't know. Can you see these pictures here on the screen? Pretty good. Okay, so this will correlate very well to what we talked about last time, right? Yeah. This is how we got to it. So the first group was, they call this a regular acupuncture group. Okay, and they treated what we call GB20 and GV20. Remember how we talked about on top of the head here and there? So that would be what regular acupuncture. Okay, so that GB20 is where the obliquus capitis inferior is, and that's where the atlas sits deep in there. Kind of, you see where I'm sort of moving my mouse. If I scroll down, what we talk about in the second group, and they call it a 7 acupuncture or acupoint group, they added some other points, all right? Right? 2 versus 7. And what were the points that they added? Well, they had those same 2 points, which is GB20 and GV20. Then they added this GB12 point, which is, what did we talk about that last time? That was the one that we were pushing right behind the mastoid process. That's where it sits with the splenius capitis. That's the superficial, the sternocleidomastoid is the superficial layer, then splenius capitis, and then that deep one, which is a longissimus capitis, which is correlated with the highest amount of muscle spindles there. So you're like, oh, okay, well, all right, Harrison showed me these things last time. All right, now we're putting a little bit of other science just other than trigger points. And then they added, so if you think about that, would be 2 points on one side, right? Then they added these other ones. This is the bladder 10, and this is the governing vessel 16. And if you can appreciate where these are, hey, that is, I have here where it's the upper trapezius comes up to the nuchal line here, correct, right? But what is underneath that? And that is our rectus capitis posterior minor, which is associated with the suboccipitals, which is associated with the highest rating of proprioception and muscle spindles as well. So you're like, okay, well, we know proprioceptively these things are related, but now we're like, oh, cool. Well, now we're just hitting a couple more points, right? Here's the cool thing. So here are the results. I'm kind of putting this. So they had these people in 2 different groups. Overall, the vertigo and everything improved all groups, okay? Which kind of makes sense. But what they found was that the individuals who had those several different soft tissue points I went to was superior to those in the regular acupuncture and medication group, which is really cool. And you say, well, okay, well, what do you mean superior? For the most part, how they concluded that, I'm going to scroll down. And again, I'm skipping all this. You can read this. They had a 93% what they call effective rate versus a 76%. And that's a pretty big difference. Imagine getting a 93 on a test versus a 76. So that study, I think, kind of can show you that, hey, we are treating these points. I'll stop sharing. We are treating these points. Uh-oh, where'd you go? I think I lost you again. I'll just wait till you come back in, sir. Hopefully that wasn't me. Messed her up. Sorry for anybody watching the video. I'm just waiting for Sarah to come back in. I think we got disconnected. And here she is. No. Sorry. I'm not sure what... It disconnected once, and we fixed it pretty quick. We're going pretty much halfway around the world to New Zealand, so that potentially could be the reason. So sorry about that. I have a little delay on the recording. Let me just share you. Here she is. Okay. All right, we're back in action.
I'm back now.
Okay.
I'm on my laptop and it won't cut out. I was on the iPad that my kids had used and it was flat.
Yeah, that's fine. So I was basically, I think you only left once I flipped my screen back to me talking. But did you hear the thing about the 93% versus the 76%?
You said 93%, and then I didn't get anything else after that.
So basically, the results was that everyone improved, which happens with most interventions, right? And for the most part, what we're trying to do is like, hey, how can we improve people more, right? And that's what this component's about. So they had what they consider effectiveness rate of, they call 93% with if you had the 7 points. So the points that we pretty much talked over, plus the suboccipital, if you want to think of that as a fascial versus acupuncture, versus just the 2 points. So it's like, okay, well, that's kind of why I did the soft tissue, that we're kind of adding a little bit of this concept together. So that study was just looking at vascular flow. So that's hopefully kind of connects, all right, well, what happens when we put our hands on somebody? It feels good. It opens up the OA, allows somebody to do a better chin tuck, which we'll get into in our exercise, which would theoretically help them get into a better deep cervical flexor. We know there's a lot of effects, but no one talks about the increase in blood flow. And so that's a pretty cool study. The other ones that have been performed since then, but for the most part, I think you get the point that when we talk about vertebrobasilar insufficiency, we can think of it very scary, where they taught you to do a vertebral artery test, which we'll debunk that for you if you still do that. But we can kind of take it as like, okay, is it something that I need to send to the emergency room, or could this be a component as well, right? So that to me is the big part of how you can take a pathophysiology of vascular issues and how what we can do. And this is just manual. Imagine if we added good exercise and everything else that we do to then get someone who, now they didn't have a group here of looking at the Epley, if they did the Epley, could they have gotten a less recurrence rate? To my knowledge, there is not a whole lot of studies on that, right? Unless you have read anything recently. I read a ton, and because I think it's so divisive almost between what you do, Sarah, and almost kind of what, and we do the Epley, we do all that stuff too, but we're just thinking of, hey, if you had that person coming in for that third session and like, look, I'm doing good. I just came in today because I like you. I've been doing good. You could then transition. This is what we do in our office. You could transition like, all right, now maybe let's look into, hey, where do you hinge? Where's your neck component? And then could that be overall health for the upper quarter type of thing? And then that, so you can think of it almost two ways. Hey, if someone keeps coming back around and they keep getting this recurrence, or they kind of get the relief, they don't have any of the eye nystagmus, but they still feel that offness, right? That to me is potentially, I think y'all's theory is like, hey, there's still a disconnect with the cerebellum and everything, and I agree with that. Maybe the neuroplasticity hasn't caught up yet. But then you're like, well, could there still be another road that we're just kind of missing? And That I know clinically works. I just don't have a whole lot of. I don't have like a randomized controlled trial on that, and who needs that? But that's kind of how I would recommend you thinking of it. If it smells like PVV, if it looks like it, and you treat it, boom. Let's just say a simple PVV case that's like 2 or 3 sessions. Could this even be a way for you to like? But you don't own your own business though, right? Do you say?
Yeah, no, I do.
Oh, you do?
Yeah, we're private pay.
Oh, good. So the point is not to say, hey, this person needs to come see you forever, but I know for us, our simple PVV ones are like 2 or 3 sessions and they're gone, which is great. That's perfect. But then you're like, all right, well, could I take this and we just think, hey, how can I help this person even more, right? And that's a little bit what we do. It doesn't always sell because somebody was so bad, you got them feeling good. It depends on if they're having, let's say, a lot of neck pain and then they trust you and that type of thing.
Yeah, it's good. It's good too because we do like we're still the GPs still. If people have got simple BPPV, they're like just go and Google it and do it yourself.
Oh yeah.
Won't go there. But we do get a lot of people that come back and have recurrent BPPV. So it's a good thing for me to go, okay, well, this is another thing to look at. And does that make it better for them?
Yeah, and I would just challenge you, like, let's say you have, let's say you have a group that's coming in. Maybe you could say, look, you're doing good here. Then maybe we haven't gotten to our exercise stuff yet, but potentially you could do your technique so they kind of feel what that is and you go along here. But then when we get to our exercise techniques to improve cervical extension at that mid-cervical spine, potentially you could just see if there's any relationship over, a period of time. Of course, you don't have to do a real study, but it could be. There's so many other factors, right? You have vitamin D, you have, it's just so many other factors. But I think this is a little bit of a missing point that has some holistic approaches to it as well. And I think it's going to help your people that you see. Maybe that person who has it like once a year. I mean, that may not be. I mean, maybe you can do this and you won't see them. I have a few of those over time, you may find that this works really well for that percentage of people who just kind of, they get better, but they're just not quite that,
Yeah.
And I think that's where this stuff shines. And of course, you could make sure you rule out any type of, food and protein and fiber and, all the other stress and everything else as well. But, that's, I hope, can connect the dots a little bit for you. The other component, which it's on the end of that book, I'll just tell you now since we're on it. I think we'll talk a little bit more about this with our exercise approach, or no, our vestibular one when we talk about cannula repositioning. But the Maccarelli, it's a Italian group, and they look a lot about cervical range of motion and BPPV, and for the most part, it's like if you're limited in cervical extension, I'm drawing a blank on an exact number. Let me look back at my book. You're 10 times more likely to get recurrence. So let me. Sorry. All right. It's the 2019 Marta Lucici author showed a univariate regression analysis. A lower extension was significantly associated with multiple canal repositioning maneuvers. So this was this was more multiple procedures needed to do it, a 10% increase in odds. And I think we have some more studies on that too, but that's a good group out of Europe that's connecting some of these groups. I'll put in my notes to look and see if it's any newer. I look at a lot of research. but I'll put in my notes to just see. Yeah. Okay, so, all right. So anyway, because we're trying to get extension, right? And when we talk about our vestibular positioning, we'll show some, and you probably know a lot of the modifications to get somebody into extension, but we want them to get extension, and there's not but so much extension that we're going to get when it's all hinging at that C0 to C2, that upper hinge. I mean, it's just this is as far as it'll go. If you think, let me just nod. If there's nothing moving in between there, which is kind of our other approach. Think about if I just do nodding here, that's my limited with extension. If you're just hinging C1 or C0, C2. But if I actually can get that mid-cervical, then look at the difference in that range. So potentially that's a little bit of a maneuvering thing that could help them, if you want to think of it that way, as well as some of the repositioning stuff. So did that answer your question at all? I feel like
it did.
Okay.
That's good.
So it's two components: the vascular, the studies with that, and then the actual extension that, again, we'll get over with our vestibular section. And your other question, how to use treatment to help, that's just kind of talking the soft tissue manual stuff. So that study actually we had created, that was 2018. We wrote all this stuff like 2016, 2017. So we had already had this, I call it physio blend, because it's a blend and it's an art kind of form. It's this and that. And it was cool to see that some studies like, oh, okay, that's why I don't just push here, push there. We kind of do the whole package. And that, your setup is probably a little bit more similar to mine, where you could spend the time to here, and then the suboccipital work, which is hitting that other ones, versus if you were kind of just a one-time adjustment here and there laterally. So it works for my cocktail as well. But so cool. That's not even including the joint stuff. We'll get to joint. I think that's week 5. That's next week. And that's kind of where most of the older research really goes into. They just don't do it vascularly, and it's not a lot of connections with PV unless you get into the osteopathic. I'm just talking about literature and research. The osteopaths and the chiropractors do it. Chiropractors kind of do them a little bit more of vestibular kind of stuff now, but that's how all that was sort of treated. And I know the Epley does it, and all the maneuvers that have been designed since. But again, that was only started in 1983. So, people might have struggled a ton. We know that a certain part of BPPV just kind of resolves on its own as well. But potentially before 1983, for the last 100 years, chiropractic was not around. Physio didn't start in, I don't know about you guys. I mean, I guess it's the same, 1921, right? Is that, I guess we're all the same.
Yeah, I think something around there. Just had the 100-year.
Yep. Yeah. So, we didn't start till 1921. Vestibular didn't come around. I don't even know if you guys came around till like the late 80s, early 90s. I don't know. You might know.
I came back from the UK. To New Zealand. I was like, went to one of our major hospitals. I'm like, right, who's doing the vestibular stuff? And they're like, what? And that was like 2010. So it's.
Oh wow, yeah. So the good thing is a lot of stuff has really improved in let's say the last 15, 20 years in vestibular. I think it's just blown the surface. What this component is just say, what about the stuff that's been used before, but how can we incorporate it into this bigger picture and put the two together? And that's kind of sort of the way I look at it. I mean, it's kind of old school stuff, but we didn't have ways to study this a long time ago. And not many vestibular people are going to do it because they're not going to, professors and stuff do the studies, right? But what are they going to get out of? They don't acupuncture. They don't do that. So it's going to be a tough way to connect the dots a little bit here. So you kind of have to take some of the literature and then entwine it, and that's what we've done.
It's really interesting. So when I was in the UK, I worked at the National Hospital for Neurology and Neurosurgery, and 70% of my job was in outpatients doing vestibular, and we had a neuro-otology clinic. And I kind of learnt mostly there because I come over and done a little bit of vestibular, and we didn't see BPV. It was all peripheral UVH, probably triple PD, but it wasn't called that at that time.
Sure.
And we used to, as part of our protocol, we do like times 1, times 2, balance. And then we'd always do like cervical retraction and like transverse abdominis, trying to link everything together. And it was just something, when someone teaches you that, and I've never been able to find any literature or anything. Not that I've done a massive deep dive in it, but I've never, no one else has ever come back to that. But it's kind of like almost coming full circle again for me, not, just linking the body back together.
Yeah. And I think when we get to the exercise part, and I'll maybe try to spend a little bit more of that, we may even go into that when we get into the vestibular stuff, because you already kind of know that. We'll add more, and it'll be some really cool stuff I'll show you, because that's what I've been focusing on for 15 years. And just to kind of get, it sounds cliche, but help get that lordosis as much as we can, and then we connect it to the kyphosis that comes around. And some of the treatments we talked about, sometimes treating here will be effective, but sometimes getting here to get up is going to be what's going to get somebody over the hump and kind of help you kind of picture all that together. I think it'll be great. So yeah, it flows. All flows well together. And when we get to that kind of stuff, it's not potentially a right or wrong thing of what to do at that point. I have certain data points that I'll tell you, things that I try to aim for. But people already should be, even if you like get 70-80% with these, people are feeling better.
Mm-hmm.
It's so, all right, cool. I had some notes here. Let me just see. I think we talked about that. Okay. Well, it's just me and you. So what other questions you might have with that component, or anything you might have seen? Okay.
Nothing. It's just about me now thinking about it, putting it together, and I need to get a new assessment form to make sure I've got the prompts, because that's the hardest bit, is like going from, okay, I've learned this, now I'm putting it into practice.
Yeah. I would say the easiest thing to do, because you've been practicing a while and you're just trying to, I think for you, I would just take 1 or 2 of those soft tissue areas and just practice that with, almost everybody, for the most part. Yeah. And just try to say, all right, let me incorporate this in. And then, you can skip some of the, if you want to, you can skip some of the diagnostic stuff and just say, that, and you just kind of go in to treat, and you just kind of see what that response is. And then sometimes what that would do is then you can take a step back, and then when you do some of your assessment, then you start to connect the dots going in the other direction. But instead of like trying to figure it all out, like I need to examine every single thing with everybody, just that's a little bit how I learn. I know a lot of my colleagues that are like, hey, I need to know the X's and O's before I put my hands on some people. And you've been treating long enough, you know how these people are. And you, just like you told me last week or week before, you just kind of, that person who's in the trouble with the VOR stuff, just kind of go in there and just see if some of these may make those more effective, which would increase performance. You get the idea, and then make them feel better. And we know it does. I have a study coming out on cervical ocular reflex, the COR, and basically they looked at 8 weeks of chiropractic stuff. That's this is just spinal manipulation, and basically that just improved. They actually tested it, in laboratory tests, and so that literally just came out like 2 weeks ago. So like we're seeing a little bit of this stuff that, and people are like, okay, well they've been doing that for a long time. That's nothing new, but we're just kind of seeing it relationship to what we do. And then of course you got your other training mechanisms that we know how to do as physios, and it's not just a pop here and there. If they do need the other procedures, but so yeah, I think I would say for you, obviously keep treating the BVVs because the stuff works. Treat them the way you do. If you can get that buy-in, maybe that third visit they're doing good or however you do it. We kind of taught our staff, like, obviously tackle it the way you do it, obviously with a therapist, and then it's like, all right, then you can just see if you can start to open, and because they're going to say, yeah, I've been having this for a long time or this or that, and then you just see if you can go down that pathway, and that could of course just improve overall outcomes of how they sleep. They don't have I need to explain this to you too. So that would just help them sleep and all this. Oh, one other thing. I meant to make the connection. Let me write this down. Sleeping. Okay. Sleeping and on one side and how that relates to BPP. Okay, sorry. I have a theory on that. So here is something you could ask too. Sorry, I'm all over the place, but
no, this is good. This is where our brains go, right?
Yeah. This has been in my head, and I just forgot I don't have anything in my lectures on this because I have no science behind it. But try asking this question too when we talk about recurrence rates. Ask the people if they just sleep on one side or the other. Okay, and you probably even have a preference as you've been on Earth for long enough. And the question is like, well, what makes us just lay? Why are we more comfortable in the right versus the left? And we talk about symmetry. We talk about, hey, in a prolonged position of 6 hours, 8 hours, and we never go and we have that same stimulus to the other side, could that be contributing to? I don't think it's contributing to BPPV. I don't have any science behind that. But I mean, I don't know. Like, if you take 24 hours a day and you say, hey, I always sleep on my right side, and 1/3 of every day for a long period of time, and we're talking about fluid mechanics. So, but the thought is like, well, what can we do musculoskeletally? Because I would ask, like, well, why do we? It's for comfort for the most part. Maybe your spouse is on that side, or maybe your spouse is on that side. You got to roll over because you don't want to face your spouse, or whatever. But I would tell you, on my experience, on what I have done on my body, I used to always favor my right side. I just always slept on my right side. And when I started my symmetry, some of the stuff that we'll teach in my exercise approach and some of these hinges stuff, I've slept on my left side more than I have in probably 10 years. And I don't have a study and somebody's videoing me and me doing it. And my thought is from a neck component at least, not anything else or jaw or whatever, but when we're laying on our side, our neck tends to, imagine a pillow, we're going to have a side shift there. And if we have a restriction going one way, well, it's going to be a little bit uncomfortable. So when we get to the joint component, which is next week, I really break down different mechanics of how you can assess. We talk about C2, C3, but it could be the entire spine. But one of the levers that we do to treat is side shifting. And it's a little hard to do here, but it's kind of more, we have side bend, right? We have rotation. But if you're trying to really mobilize a joint, we add this thing we call side shift. And what it does, it kind of allows you to get up onto the articular pillar at that zygapophyseal joint. And so what I'm getting to is that takes a lot of effort, but see if you can connect any dots. And I would love to do some sort of research if I get more vestibular people. The side any connections on the side of their PPV, maybe the recurrence rate, and if they just sleep on one side or the other, and if it's connected. I don't know if you know any studies or anything, because the thought was like, well, could that be another recurrence factor? But instead of just saying, you need to lay on your left side and tape you down, like, can we do something somatosensory wise to make it more? And some of that's here, but honestly, some of that is how we treat that, which is a little beyond our course, but how we get the symmetry all between the thoracic spine and the wings and the lats, get it all getting all here. So, but a simple way to think of it is side shifting. That's why people like thicker pillows and stuff, because it doesn't have that side shifting component when we're laying on our side, especially a really broad surface person or something like that. So anyway, sorry, I want to just bring that up, just see if maybe just something to ask.
No, but I've got a question about what you think about this. So I've got a client who has had a concussion, plus he's had ongoing headaches and things. And we were talking, I actually did some soft tissue stuff, and he was really, really tight through his left side. But he's got a CPAP mask.
Yeah.
And so he was wondering, like, he wakes up with a headache even with that on, and he's wondering how much it's pulling him into, like, pushing through into his neck and affecting his headaches and his neck position. And is there anything you can do about it to release it? Because if it's not tight, like, you can see it, like, he's got a mark on his face where it's been there. Any thoughts or any experience with that? Completely randomly off the topic.
No, it's a great question. How long has he had it? Do you know?
The CPAP or the headaches?
Or both. Or I'm thinking CPAP.
It's been for a while. I don't know how long, but 2 years, something. Yeah.
Kind of wondering.
He's quite young. He's only in his early 50s.
Yeah. I guess what I'm thinking is, like, is his headaches? Is it not enough continuous pressure for him if he's gotten worse in his health? If it's been prescribed a long time ago, maybe it needs to be. But musculoskeletally, that's a tough one. Here is a thought on those. He probably is going to be in a little bit of a jutted out position. And so if he lays down, he probably doesn't have the capability to go, think about, this is my pillow, to kind of rest down. So the head is going to be in this posture. And the thought is he's in a sustained cervical extension posture for a period of time. And short-term stuff could be, hey, double the pillows. He's going to need to be in a more flex position. He won't be able to be flat. Longer-term stuff, from your end of things, could help address if it is so gnarly up here that it's just not improving. If he's not getting the cervical extension, you may need to help with some of that kyphosis and some of that work too. Because if you're laying down, if he's already like this, then for his contact with his head, it has to go up. So you could potentially go down that pathway. That's going to take a little bit of time. It sounds like if he's...
Well, interestingly enough, he's got a musculoskeletal therapist who's working with him, but he's got dish through his thoracic spine, and he was
That's a bummer.
And he fell. He fell onto some rocks, and it's made it all worse. He's got lots of pain. So, there's lots of stuff going on.
Yeah, that's a handful. I would say, and you'll maybe get some of these techniques. I would say, especially as I think hitting his CT junction is going to be a big thing. And I don't know what his other. Feel free to ask him what stuff they do at the other musculoskeletal. Hell, he might just be doing bands and stuff. So I always dive in because I think that's going to make a big difference but I would keep doing what you're doing, just see if that makes a difference. It sounds like it's going to take a little bit. I always tell people too, he probably going to need to be a little bit stacked up on his pillows. You could dive down into like, any type of hydration at night. If he has anything high sugar content that could be contributing, like ice cream or something that he does every night. You could help, and we'll learn a little bit more on this on our side. You could say, look, before you go to bed, about 30 minutes, here's a 10-minute routine that you need to get your body moving a little bit, see if it helps. Those would be some of my thoughts that I would go after. And because, that's miserable. The only other thing, and it just doesn't work as well, sometimes you can use towel rolls and stuff to sort of put it in the mid-cervical spine. So roll up like a simple towel roll. And then when he lays there, it gives him a little bit of it fills in the gap of the pillow and his neck where it doesn't have any play, which is the same as some of those orthopedic pillows that have the curves. This is just the poor man's version to see if it works. That would be how I would strategize it and then try to figure it out. Yeah. Unless you need to attack the jaw. Usually the jaw will cause a headache in the morning. Usually it's going to be more contribute here. If it is the neck, he's probably going to have something that may contribute here going around. But if it's kind of more temporal stuff, I would probably think of this. And that's a whole... I don't include that in my stuff, but it could be as simple as see if he can get a night guard. That may be a little bit of a simpler thought. I don't know if that helps. Yeah,
No, it does. It's good. It's good to just someone else's thought patterns.
Yeah, but that would be the strategies I would look at it lots of ways, but cool. Yeah.
Do you guys have time change coming up, or do you have daylight savings?
We do. October 2nd. I don't think ours is till mid-October.
Okay.
November 3rd, actually. It's another month from now. Yeah, it's a little later. That's weird that y'all's are... Yeah, so technically we should be all done by the end on us. So, it's interesting. Yours is so early. That's interesting. I don't know.
And you guys all right as well? Did you have any of the hurricane? Like New Year?
So I am in North Carolina, which we got more rain here, which we're way up the path. The western part of our state, it's like 1,000-year storm. It's horrible. We are actually supposed to go out in 2 weeks. We always go in the fall here. We go out there, and I think it's just not going to happen. I mean, I think the most deaths in a hurricane in the U.S. This is a very Appalachian mountainy area, and that storm just sat there, and it dropped about 30 inches of rain, and it was already higher. We've had a ton of rain. It's already higher rain content. So, yeah, thanks for asking. I luckily don't know or have any family or anything out there. We were fine. I mean, we're in the middle of the state, and we were absolutely fine. It's interesting because the coast in the United States, the North Carolina coast, got hit a week or two before. They dropped about 20 inches on our coast, and we were just sitting right in the middle. We're like, something's going to happen. Sometime for us, it hit us on both ends. So that's funny. I guess you guys get that news, but yeah, it was bad. It was a huge storm. This is my sister just sent this. I don't know how well you're gonna be able to see it, but whoa. All right. Ooh. So you see where the top is what lights are in the U.S. and the bottom is where where it's black. That's where all the power. That's the storm, and it just like blew things away. That was like a satellite image. It's kind of wild. Yeah, that's wild. So. All right. Cool. Yeah.
I should be there next week. I've got a patient at 1:00, but I'll hopefully change her. But if I'm not there, I'll be there the next week.
Okay, great. Well, yeah, bring any questions. I'm hoping we'll have everybody, sometimes in the U.S., this is it's 8:00 at night on the East Coast. We've got people West Coast, and but we recorded, and so hopefully they'll grab it. And so anyway, but all right. Sounds good.
For me, I get to ask some questions.
Yeah, no, that's perfect. This is fine.
Thanks, Harrison.
Good deal. All right, we'll see you next week.
Have a good day.
Bye-bye.
Bye.